So welcome to the two-part webinar series, Analog versus Digital Removable Workflows in Your Practice. This lecture is being presented by Tremaine Watkins, CDT. Today is part 2, partials, review of theory, analog and digital workflows, materials, indications. And with that is my distinct honor to introduce Tremaine Watkins, CDT. He is the NDX Director, Training and Development. Tremaine has been working in dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He also has provided clinical support for case planning, troubleshooting, and implant management. He has trained over other technicians in all aspects of dental technology, and has written and lectured on several aspects of restorative dentistry. Oh, thank you, Tremaine, for joining us, and take it away.
Thank you very much for joining tonight. We're going to be talking about partial dentures tonight. As you guys know, and as you probably remember from last week, this is a very fast-moving area from the digital manufacturing side. So as I was looking through the presentation today, I was kind of reminded that we're really going to be focusing on the fundamentals of partials. I think you guys will find that this will be very helpful as you're working with your laboratories, coaching your laboratories to make sure that you get the best result for your patients. We'll talk about kind of where digital manufacturing is right now, and then we'll kind of talk about at the end about digital records and how that can help speed the process along and make this from being a kind of a lost leader oftentimes in the practice to become a good source of revenue. So let's jump in. This is my presenter disclosure. I'm a full-time employee of National Dentex, and I've been paid to do this presentation. But other than that, I'm not receiving any financial help from anybody or anything like that. So when I'm presenting workflows and different things like that, it's not because I am getting paid for it, but because I think that it's something that'll be helpful for you and your patients. I really wanted to call out these two resources. Both of these are available online as PDFs, and these are, you may have seen them at dental school, but these are really, really nice materials. I feel like it, as I was reading through them, I've been working with partials most of my life, but in labs, it's often tribal knowledge. And when I wanted to present on this, I'm like, I got to do better than tribal knowledge. I got to have some good clinical information. And I felt like both of these presentations really laid out partial dentures in a very step-by-step process. So if you're looking for some good resources, these are them, in my opinion. All right. So why are we even talking about partial dentures in 2024? As you guys know, with the advent of root form implants and very predictable hard and soft tissue grafting, it's rare to find a situation anymore where we couldn't place an implant, like in our little picture here, and restore it with a crown. But, you know, implants are expensive, and we all have patients that either don't want to go through the surgical procedure or can't afford it or don't want to afford it. And so then we need to be able to help them with a partial denture. You'll oftentimes have patients as well who may have a cleft palate or large post-surgical defects if they've had cancer treatment or something like that. And then partials can be a great tool for them. Not only that, but even with implant dentistry, a lot of times we'll be using a partial denture as a temporary prosthesis, either while the implant's healing or if the patient's too young to have implants placed or something like that. So I feel like there's two sides to this. One is that we want to be able to treat those patients who choose not to have implants. But I think on the other side, we want to make sure that this is a different presentation, but we want to make sure that we're able to present to our patients the value of an implant retained prosthesis. A lot of times they might say, oh, well, I don't want to spend the money, but you know, you want to talk about bone loss and just different things like that so that they understand that implant treatment is maybe more expensive to them, but it also is most people I think would say it's a better treatment. Feels more like their own teeth. So I think one of the takeaways from this, not directly related to partial dentures, is we want to make sure that when our patients come in and they're missing teeth, we want to talk about all the options that are available to them and kind of costs and benefits. So I'm off my soapbox now on that. So let's talk about Kennedy classifications. A lot of times over the years, I kind of felt like this was like a trivial pursuits thing. Like, who cares about it? But the reason that we have these, as you guys probably know from school, is that there's 65,000 possible combinations of teeth in edentulous spaces. So to make this manageable, they've been grouped into these 4 classifications because we need to kind of talk about each different classification is going to have a different strategy for the partial denture. And then later on, Dr. Applegate in 1954 kind of added some rules to kind of help use this more effectively. So we got a sample case, couple sample cases in 2 slides, and we'll talk about how we use, like, why do we need to know this? How do we use it? As you guys know, Kennedy class 1 cases are gonna move. Like, when we're designing these partials, we need to design them so that when they move, they'll still have retention, and that we can cut the movement down as much as possible, and we can kind of spread the load from these large posterior saddles along the teeth. Kennedy class 2 also going to move, but they have an axis of rotation. In this particular situation, the axis of rotation would be here. So we want to make sure that we put an indirect retainer to resist that. Kennedy class 3, we should be able to make those pretty stable because we have support on both sides. And Kennedy class 4s, depending on how large they are, we can usually get them pretty stable. But one of the things we got to deal with these is the aesthetics of them. Sometimes getting a nice looking case on a class 4 can be very, very difficult. So we'll kind of work through this and talk about how we approach some of these different situations. So there's a few different rules for Applegate to, like, how do you apply the Kennedy classes? And so the first one, obviously, is that we want the mouth to be stable before we decide what classification's in. So if we're going to extract some teeth, we need to get that done before we classify it. Then we need to kind of look at the molars and decide, are we going to replace them or not? If we're not going to replace them, then they don't come into our classification. If we are, then we need to deal with that saddle. Rule 5 is really important because sometimes we'll have cases that look like, oh man, is it a class 1 or a class 4? And what we want to realize is, because of occlusal force and the like, where the most posterior space is determines what classification it is. And we'll talk about that on the next slide that's coming up. Edentulous spaces that are kind of scattered around but don't really affect the classification, we're just going to call them modification spaces. And the size of them doesn't really matter, it only matters what they are. Last but not least, there's no modification spaces for a class 4. So let's look at a couple real life cases and see why we would, how the Applegate modifications come into play. So let's say that on both these situations, all the extractions have been done. So if we look at the maxillary arch, in this particular case, we're not going to replace tooth number 2. So that would change our Kennedy classification, because it would be a class 1 if we were replacing it, but now it's a class 2. So obviously that's going to make a huge difference in the design. It'll change the type of clasping we'll use, would change the amount of coverage on the arch. So that one tooth, making a decision to replace or not to replace, makes a huge decision on this. So, and the mandibular arch is interesting because, you know, it looks like, oh, is it a class 1 or is it a class 4? But this one is, because we want to look at the most posterior, this becomes the Kennedy class 1 with a anterior modification space. So again, will be, the way we design the partial will be quite different since it's a class 1 rather than a class 4. So we want to make sure that we look at our cases and kind of group them into these categories so that way we can kind of decide the best way to design it. So next we're going to look at the different aspects of a partial, and then we'll talk about how we put them all together for different classes. So partial dentures, as you know, have 4 components: the major connector, the minor connector, well, 5 direct retainers, indirect retainers, and then the denture base itself. So the major connector it connects all the components of the partial denture. It's the main component of the partial, and it needs to be as rigid as possible. We don't want it to have any flex, and it'll connect all the other pieces. So then the minor connectors connect individual components of the partial to the major connector. A lot of times, and we'll talk about this later, you can use the minor connector for other things, such as a guide plane or something like that. So be thinking about how you can make those not just a tag along, but something that actually does something functional for the partial. Direct retainers are the clasp assemblies, basically, and they're the things that actually hold the partial in place. Indirect retainers are rests. As you can see on this particular case, it's a Kennedy class 2, and that indirect retainer keeps the partial, it keeps the sala from raising by resisting the fulcrum effect from one C to the other C, basically. And then last but not least, we have the denture base, which is the point of the whole thing. And especially with the class 1 and class 2, we really need good adaptation on our denture bases, because that's the best way to minimize movement and also to try to stave off bone loss due to force on the bone, external force on the bone. As you guys know, residual ridges that are loaded internally by a tooth or an implant tend to stay, whereas residual ridges loaded from the outside, like with a partial or denture, tend to resorb. And so we want to minimize that process as much as possible, while at the same time warning our patients that it is going to occur with removable prosthetics. So partial design methods. Today, there are 2 ways we can make a framework for partial denture: analog or digital. The left-hand image shows kind of how you would design a partial old school analog way, and then the right-hand image shows how you design it in 3Shape software using a digital method. Either method can be effective, but the analog process is very time consuming. And there's a couple of steps, especially the manufacture of the refractory model and then the casting of the partial, where despite a person's best efforts, you can lose the whole case and have to start over. Right now, the best way to make a partial, like a metal partial frame, is with digital SLM printing technology, which is pretty expensive, but I think it's the best way to do it. And talking to technicians who do this all day, every day, it's made such a big difference in our industry. Like, it's made partials from being something that's can be kind of frustrating and unpredictable to make it very, very predictable. So, in general, I'd say laboratories are adopting digital removable technology much faster than fixed. Because when fixed CAD came out, it was like a revolution. We went from being the last 18th century industry to being a 21st century industry in about 15 years. But I think now that most laboratories that are successful or around have kind of gone through this transition on the fixed side, the removable side's going much faster. The main challenge right now is digital printing technology. As you guys know, right now, subtractive technology, milling, tends to be a little more precise, but it's slow and it's hard on the equipment. So 3D printing is kind of where laboratory technology is headed. And so the only real limitation right now is, can I print the material that I want to make with a 3D printer? And we'll kind of talk about that as we're going along for different kinds of partials. So let's talk about surveying a partial. The first step in designing partial denture regardless of whether you're doing an analog or digital, is surveying the partial. We can use a digital or an analog process for this. We're going to talk a little bit about the analog method because the digital process is built on this analog method, but it makes it much simpler. So if you think about a partial denture, it's like a really, really big removable fixed bridge. So there's usually a substantial number of undercuts that need to be blocked out, except in the case of our direct retainers, our clasp assemblies, which actually need to engage an undercut. So when we do our block out, we want to make sure that the path of insertion we set is something that the patient can actually do. So usually what we'll do is set up the case like you see on that left-hand image so that the plane of occlusion is either parallel to the bench top or slightly tipped up in the anterior like this. If we create an odd path of insertion based on undercuts and stuff like that, the patient will have to be able to use that every day, taking the case in and out. In general, we don't want to set the anterior teeth lower than the posterior relative to the bench, because what that's going to do is it's going to require the patient to kind of go backwards when they're taking the partial out, which can be kind of difficult. I realize that a lot of times this is something that your laboratory is doing, but it's good for you guys to know what's going on. And obviously you guys have a lot more knowledge than most of your technicians do. And this is a way that you can kind of coach your lab to make sure that they're, that you guys are working together to get the best result for your patient. So once we figured out what the survey is, we're going to set the height of contour, as you see on this right-hand image. And everything below that needs to be blocked out. And that's one of the areas where digital really shines, because when you're doing this manually, you take the master model, you mark it, you put a bunch of wax on it, and then you take a scraping tool in this surveying unit and have to scrape the wax. And so you're trying to get it so that it's perfect. But with digital, the software just does it. It does finite element analysis basically and blocks out the absolute minimum that we need. Then once you've looked at that as a technician, you can set your undercut exactly how you want it. In general, for a cast clasp, we'll want to do an 010 undercut, which is about 0.3 of a millimeter. And for Rottweiler, we'll want an 020 undercut, which is about 0.5 of a millimeter. Because we tend to, in our digital software, we're tending to work in millimeters, whereas in the old school surveyor, the little undercut tool was in inches, basically. So what are our fundamental goals of a partial? We need to look at it and see, does it meet these requirements? Of course, retention. We want to make sure that the partial isn't easily dislodged during chewing or moved during speech. On the other hand, we want to make sure it's not so retentive that it's difficult for the patient to remove. So we got to find that nice balance. Most of the time, this is the simplest objective to achieve unless there's something odd with tooth morphology. Stability. Perfect world, we don't want the partial to move at all. Difficult with Kennedy class 1 and 2 cases. I'd say impossible with a class 1 and difficult with a class 2. With class 3, we should be able to make it stable. Class 4, it depends on the case. But we definitely want to be thinking about this, and we want to be thinking about it with all the different aspects of the case. So in other words, we need to be looking at this not only with the framework and the clasp, but also with the fit of our saddles. The better the saddles fit, the less movement the case is going to have. Now, this is one of those areas where patient communication is really important, because if we're doing a class 1 case, we know it's going to move. So part of our conversation with the patient is, if we make an implant supported prosthesis for you, a crown and bridge case, then it isn't going to move at all. If we make a partial, it'll move a little bit. How much? Well, it'll depend on your anatomy and how you use it, but just know that it's going to move. If you've had that conversation ahead of time, good. the patient, especially if you have them sign a document that says we've had this conversation. Then if it moves, there's no frustration or whatever. You just say, hey, patient says move. You said, yep, you're right. It moved just like we talked about. But, you know, again, good communication ahead of time can sure take care of a lot of finger pointing at the end. That's really important. Our support is kind of a double-edged sword. So the partial needs to support the surrounding tissue. So sometimes it's going to be supporting the cheeks or the lips. And we want to make sure that it provides appropriate support, but not too much. Also, we want to make sure the partial itself is well supported. Again, that it has good adaptation to the ridge, good adaptation to the teeth. We want to make sure that the teeth that we're using to support the partial are strong enough mechanically and periodontally to support the amount of teeth that are hanging from them, so to speak. And we want to make sure that our clasp designs don't overload given teeth. And we'll talk about that when we get to the class 1 and class 2 cases. We also want to make sure that our denture bases are as large as they can be on tissue that's stable, and we want to make sure they're not contacting, they're not too far extended in the vestibule or other areas to where they're irritating mobile tissues. Of course, we want the case comfortable, and in some ways, this is the culmination of the first 3 items. If we do a good job with retention, stability, and support, we'll probably have a fairly comfortable partial. If we don't have a comfortable partial, we kind of need to think about which of these requirements is not being met. And usually when we address that, we'll also deal with comfort. Of course, the finish of the partial in the laboratory is also very important. And last but not least, aesthetics are important. And we need to kind of talk with our patients about the aesthetic trade-offs that are intrinsic to partials. Sometimes, for instance, as you look at this partial, the patient may be able to see those metal clasps on the premolars. And that transition line between the pink and the gingiva, and especially the little step, you might say, between the teeth and the partial teeth and the natural teeth are sometimes going to be visible. We need to kind of think about how that's going to look, try and show that to our patient, and make sure they understand that oftentimes there are some aesthetic trade-offs with partial dentures, and we want to make sure that we have talked about that ahead of time. So again, I'm sure you'll find this is just because in my life, and I'm sure you guys have run into this too, some of the worst cases, the most frustrating cases I've run into over the years have been ones that are essentially communication problems. Either as a laboratory, we didn't communicate well with you as the clinician, or sometimes you as a clinician didn't have as clear a communication with the patient at the front end about what we could deliver. And so that can lead to unmanaged expectations that can often be a source of frustration for the patient. So over communicate, especially at the beginning, because if the patient understands what they're getting and then they get it, great. Don't forget that I guess you might say adage, truism, under promise and over deliver. Make sure that if you're concerned about aesthetic or other problems on a case, I would present a less favorable outcome to the patient at the beginning. And then that way, if it comes out better, great. They're going to be pleasantly surprised, which is what we all want. Here's a few general rules for partial design. Less is more. If you can do a partial with less elements, that's better. A smaller partial is more hygienic and usually more comfortable. So if you can do something with 3 retentive elements or 4, the 3 is better. Base adaptation, we've talked about that a couple times, very, very important. If the plastic fits the tissue well, the partial will be less mobile. Use what's present. If at all possible, if there are spaces in the occlusion, in the bite, then we want to put our rest in those spaces, so that way you don't have to relieve good dentition for rest. If we have to, we have to, but if we can get a little bit creative, that can be a good thing. We want to make sure we plan for the future. So especially, let's say a person is missing one mandibular incisor, but you see that the other three are mobile, we'll probably want to use a metal partial with a lingual plate so that we can easily add those other teeth without having to remake the whole partial. But whatever the patient's situation is, you want to make sure that if it looks like other teeth will be lost, either let's extract them now while we're doing it, or let's plan for their loss. Let's not have a key clasp on a mobile tooth, because then we know we're going to have to redesign the whole partial if that tooth is lost. We don't want to have occlusion on the rest, so we want to make sure we have enough space interocclusally in the rest areas, or we need to plan for relief in those areas. And then on the denture teeth, we want to make sure we have group function in excursions as much as possible, so that we don't have tipping forces on the partial. Like we talked about last week, this can be for a class 1 case especially, we'll probably want to do lingualized occlusion so that we have nice even forces, so that the occlusion isn't creating tipping forces. We want to make sure when the patient goes into different excursive movements that we check that on our denture teeth, so that way we don't have a lot of tipping forces. So let's talk about some of the different components of the case or the partial, and how we can use them. So the first thing is, for our major connectors, unless we're doing a plate, we want to have the major connector more than 3 millimeters apical to the free gingival margin. If we can't do that on the mandible, we want to use a lingual plate. In other words, if the vestibule is kind of shallow, the lingual vestibule. We talked about adding lingual plates to help with tacking more teeth onto partial, more incisors on the mandible, or even on the maxilla. And then we want to keep our palatal coverage down. So if we have less than 6 teeth present on the maxilla, then we will probably want to use a palatal plate, because that's much sturdier. But if we have less teeth than that, like on this case, we'll want to use a palatal strap, because that'll really help with taste sensation for our patients. So for our retentive grid on the maxilla, we do want to extend the grid over the tuberosities. In the mandible, we want to end them before the retromolar pad. And then Kennedy class 1 and class 2 cases, we want to put tissue stops. What those are is they're little tiny pads of metal or frame material, I guess you could say, that extend onto the tissue. So that way, if we're doing old school where we're processing the plastic, we can make sure that the frame doesn't tip when we're injecting it. It doesn't really, when the case is done, you'll see a little metal when you look at the intaglio surface, but it's mostly to help make the processing in the laboratory more predictable. Guide planes. So guide planes, what they are is they're surfaces of the partial that engage the teeth, kind of like a key and a slot on a precision attachment. And they tend to make partials more stable without adding more clasping. A lot of times, this is an area where we can use our minor connectors to have them do double duty. So when we survey the case, if we use our minor connectors as guide planes, the partial will be more stable without having to add a bunch of visible clasps. Sometimes when we do back action clasp, in other words, a clasp that kind of comes around the lingual or something like that to hide clasping, having good guide planes is really important. Also, guide planes can, sorry about that. Guide planes can, just a minute, my screen's being angry with me. Okay, there we go. Nope. Okay, there we go. I'm on a hotel Wi-Fi, so sorry, that made it a little bit angry there. So getting back to guide planes. When we add more guide planes, a lot of times what that can do is it can reciprocate our clasp without adding a reciprocating arm. And again, the smaller the partial is, the better. Guide planes, we don't want them to be just a little tiny strip of frame material, metal or clear frame or whatever. We want to be large enough to where they provide some additional stability. A partial that has good guide planes will be easier for the patient to take in and out, because it'll have a definite path that it follows. Like I said, sometimes partials, we think of them as kind of frustrating or boring or whatever, but they could definitely be an avenue for us to use our creativity, because we're kind of looking at the case and saying, how can I make a minimalistic design on this where all the components work together to make this as stable and comfortable for the patient as possible? So let's talk about our rests or our stops on our partial. So we want to make sure we have enough occlusal clearance for them. Our occlusal rests on our posterior teeth, we want them to be half to a third of the mesial distal width of the tooth. And they should be 1.5 millimeters deep and rounded when we're designing, if we have to cut rests or alter natural teeth to make a rest. The rounded internal line angles make them less likely to break, because the partial rest is the positive of whatever negative shape you make in the teeth. On the maxillary and mandibular canines, we want to use cingulum rests as much as possible. And we don't really want to put rests on incisors, because the teeth, as you know, they're just not that strong, and they can't support a major amount of loading. So if we need to use them for reciprocation, maybe on a class 2 case or something like that, that's okay. But if we're going to be putting heavy occlusal force on them, we'll probably want to use a tooth with larger roots that can resist that mechanical force. And we don't want to put rests on amalgams, because they're going to tend to break the amalgam or cause it to get dislodged. So a good direct retainer is going to have a few aspects to it. And let's talk about some of these. Encirclement, I'm not necessarily going to go through all this. Support is, I think, kind of obvious. Reciprocity, let's say that this has a buccal retentive arm. Well, a retentive arm is only retentive if it's resisted by something else. So in other words, if this clasp didn't exist, this clasp wouldn't really be retentive. So we need to have whenever we have retention on one side of the tooth, we need to have reciprocity with either a clasp or a guide plane or something on the tooth to make the retention actually work. Of course, stability is important. Encirclement is a big part of that. So if the clasps don't come past the midline of the tooth, then all the clasping is going to do is try and push the partial distal. So we want to make sure we get past 180 degrees of the tooth. If we're deciding to clasp a tooth, we want to kind of wrap around as much of the tooth as possible. And then passivity, what that means is that obviously a clasp has retention, but when it's fully seated, we don't want it torquing the tooth. We want it to be, so once it's snapped into its undercut, we want it to be just sitting there, not putting torquing force on the tooth. We'll also talk about this in a minute. With occlusal force, when the patient applies occlusal force to the tooth, we want to make sure that the clasp design isn't torquing the tooth. So we talked about this a minute ago, but with metal clasps, we need to have the right amount of undercut for retention, but not too much. When we're designing a retentive tip, this gray line is the survey line of the partial. We want to make sure that only the last third of the clasp goes into that retentive space. We want to make sure that the whole clasp isn't in there. It's going to make the clasp too flex too much, and it'll either be overly retentive or too weak, as the case may be. As much as possible, we want to have the clasp retention in the gingival third of the tooth, again, so we're not torquing on the tooth. We don't want to put too much leverage on the clasp so that it moves the tooth. We want to put that force down as low as possible. And again, in the interest of simplicity, we don't need more than 4 clasps per arch. If we have a design that has 6 or 8 clasps, that's probably a little bit of overkill, and we should look at ways to simplify the case. So thinking about the different kinds of clasping, this is the Akers clasp. I think in a lot of ways, this is kind of the Swiss Army knife of clasps. You see this all over the place. It's a good go-to. They're simple, they're versatile. The main disadvantage to them is if we're using a metal partial, they tend to have a lot of display, so it's easier to put them in the posterior. They're a little bit more difficult to use in the anterior. We'll talk about other clasp designs that are a little more aesthetic. Double clasps or embrasure clasps these are like 2 acres class, and these are really huge. But holy smokes, can these get you a lot of retention? And for the amount of retention they have, they're pretty simple. So a lot of times when you're doing a Kennedy class 2 case, and let's say that the saddle is on the patient's lower right, if you put a double clasp on the lower left, you really have most of the retention that you need. One more clasp just anterior to the saddle, and a little bit, and maybe a bracing indirect retainer or rest in the left anterior region, and all of a sudden you have a fairly simple partial that has an awful lot of retention. So these are great for getting a lot of retention in one area of the mouth, but they are large and more visible. And of course, you need to have enough occlusal clearance to, go through the occlusion. Same with an Akers clasp. So bar clasps. Bar clasp, there's all kinds of design, like you can see here. You got a T bar, L bar, C bar, I bar. An I bar is kind of a special kind, so we'll talk about that in a minute. And a lot of times the shape of this clasp is determined by where the undercut is. The picture is a little bit disingenuous because it implies that the retention is always the same. But actually, the reason that you'd use an L or a U or a T is because of how much retention you have and where it is. So these clasps are nice because they're less visible, but they really only work if we can get an undercut that's down low on the tooth, and then we don't want to have a whole bunch of undercuts. So if a tooth is tipped to, let's say, the labial, these oftentimes aren't a good solution because they're going to have so much, what am I trying to say? They're gonna be spaced off the tooth or off the gingiva so much that there'll be a big gap there. So these are best for cases where the tooth is upright or inclined a little bit to the lingual palatal, so that way we can keep the arm, this emerging arm here, nice and tight to the tissue. We also want to, we can't do these in cases where there's a really shallow vestibule, because we need to come in the vestibule and up into the undercut. So they're very versatile and helpful, but you got to have the right situation for them. And last but not least, we want to talk about an I bar. A lot of times, these RPIs, we use them in aesthetic situations, but really what they're designed for is free end cases. So we always want this kind of clasp to be directly mesial to a saddle area. And it's very important to keep in mind that an RPI always has a mesial rest. And here's why. When the patient bites down on this partial, with the rest on the mesial, this can move a little bit without torquing the tooth very much. If we put it on the distal, it has the exact opposite effect, and it winds up trying to twist the tooth distally. So it's really important when we're doing IRPIs, and I mean, us labs should know it, but sometimes we don't. So if you see a design for an RPI with a distal rest, you might see your lab, that might be a little bit better with the rest on the mesial because of biomechanics. So these are your go-to whenever you're doing a Kennedy class 1 or class 2. We want one of these right next to the saddle. So for instance, with a Kennedy class 2, on the side with the saddle, we'll put an RPI directly to the mesial. We'll put a indirect retainer on, say, the opposing cuspid, and then across arch we'll put a double clasp, and that gives you a really nice stable partial with good biomechanics for your patient. Fulcrum line, something to think about. Where is your partial going to rotate? Because if you know that, then you know what do we got to resist. For instance, let's look at E. In this situation, the partial wants to rotate around that the red line. So what we can do is put some clasping, like maybe put a double clasp on both sets of molars, and then we have and maybe an indirect retainer on the premolars there. So that way we have really good retention, and And also we're resisting that torquing force as much as possible. Again, with the Kennedy class 1, we want to make sure we put RPIs on both those premolars there, so that way, and then we'll put maybe a couple of indirect retainers in the anterior, so that way the partial doesn't lift up because of the indirect retainers, but when it moves slightly towards the gingiva, the RPI allows it without torquing those premolars. And you can see each situation. So when you're looking at a partial case, you want to be like, okay, what's the axis of rotation? How am I either preventing the movement, or how am I allowing it in a way that doesn't overload the adjacent teeth? So now let's talk about how we might design a partial for a given Kennedy situation. A Kennedy class 1. So on the mandible, we're going to want to do a lingual bar, an AP strap for the maxilla, and then we do a full palatal plate for patients with no posterior teeth, again, where we really need that super strong partial. We want to make sure that the denture base has good extension over the tuberosities or to the retromolar pads to cut down on the movement as much as possible. We want to use our RPI class immediately adjacent to the edentulous areas, and then indirect retainers on the cuspid if posterior teeth are present, and then of course, like we talked about, the palatal plate if there's no posterior teeth. If we want to if we're concerned about the retention and stability, and especially if our clasping is going to be very visible, we could consider putting an implant under each saddle with resilient attachment to make the case much more stable for the patient. So for our class 2, similar design on the major connector, and again, stable denture base. So we can do an RPI adjacent to the edentulous area, and then an Akers or a double embrasure contralateral to that edentulous area, like we talked about, to make the case a little more stable. And then we want to put an indirect retention arrest in the region furthest from that axis of rotation, which will often be a cingulum rest on the cuspid to help prevent lifting of the partial frame when we're chewing. Kennedy class 3, these are the cases where we should be able to get a pretty solid case. I mean, oftentimes these are cases that could be done with a fixed bridge if we want to. If we can do it aesthetically, it's nice to get an Akers on either side of the edentulous area, because that'll make the case quite retentive. If we're doing a full arch partial, we'll want to have like an Akers or a double clasp opposite the saddle itself. And sometimes if we're only replacing 1 or 2 teeth, we can do a unilateral partial. One of the things we want to keep in mind when we talk to our patients about these is that unilateral partials can move buccal lingual as well as mesial distal a little bit. They're not going to be as stable as a full arch partial, but of course they cover much less of the mouth, and they can be quite comfortable, especially if flexible like this. So again, preoperative communication is very important, talking with the patient about the pluses and minuses of a different design. And then with our Kennedy class 4s, as you can see with this case, we got to figure out how to hide that anterior clasping if we can, and then get those posterior clasps as far distal as possible to resist the tipping force. If we can do that, we can make a fairly stable case. Now, if we have a case like that at the very beginning when we were talking about Kennedy classifications, and we had the Kennedy class 1 with an anterior modification space, those are going to be very difficult to make stable. So we need to talk to our patient about that. I've kind of touched on this before, but I just want to mention it one more time before we talk about different materials. We're going to talk about, is it partial tooth supported or tissue supported? And usually it has to do with the material. If the material that the partial frame is made from is very strong, like chrome cobalt or a clear frame material, then we can put rests on it. And then when the person bites on it, the force of the occlusion is borne by the teeth. Those are going to tend to be preferable, because we won't be loading the bone as much, and will help at least reduce the rate of resorption. Many times for smaller partials, we'll wind up doing tissue supported or with flexible partials, like in this picture here. And those are cases where the material isn't sturdy enough to make rest, and all the occlusal force is going to be borne by the gingiva and the bone. So we want to make sure that we alert our patients that those can be more comfortable, but they're also going to, they can lead to quicker resorption, especially if the patient isn't very vigilant about doing relines when you advise them to do so. Oftentimes, class 1 and class 2 cases are not optimum for flexible partials, and we kind of need to talk to our patients about that. We'll talk about that in the materials section here. Coming up now, here it is, materials. So we'll start out with a chrome cobalt metal frame partial. These were the design that came out in 1929, and for some of us, we're like, okay, well, why are we still doing these? Especially because EU regulations have severely limited the use of cobalt-based alloys. Interestingly, though, meta-studies from 2022 of 21 in vitro and in vivo studies between 95 and 2022 showed that while chrome cobalt isn't as biocompatible as titanium, it's much better than nickel. There's been no cytotoxicity in those studies to human cells. So I think this is still a viable option in 2024. One of the cool things about this is this framework is very, very strong. So we can keep the metal nice and thin. The framework's ductile, so we can make the clasps out of the same material. And, you know, we can get our flexible clasp and our rigid bracing arms all out of the same material. And the metal and the acrylic can be repaired over time. So we don't want to overlook this. This can be a great product, and it can be done digitally. We can use laser sintering to build these frameworks. The main problem with these is that the metal clasps are unsightly, and some patients don't like metal. So you're going to have some patients that just won't accept one of these, but don't just cross it out. I think they're kind of like gold crowns. They're proven, they work well, they're not as aesthetic, but there are situations where they're the best thing. So kind of make sure that you have these in your toolbox. And we kind of need to talk about this first, because when we talk about other partials, a lot of times we're comparing, how does it compare to a metal partial? So let's talk about the other materials we can use. All acrylic partials. Sometimes these are called treatment partials, temporary partials, flippers. They're made entirely of acrylic with no frame. If they have clasping, usually they have a wrought wire or a ball clasp embedded in them. The acrylic of the partial itself is used for reciprocation, and they can't have rests. So like anything else that's mucostatic, you're going to usually see increased bone resorption over time with these, as opposed to like a metal frame that has the rests. They're usually meant to be worn while a patient's healing up, either from immediate extractions or an implant placement or something like that. They can be 3D printed today, but or milled, but most of the time they're made by heat processing, injection, or cold curing, all traditional analog methods. Flexible partials are gotten more and more popular. They're first developed in the 60s. Valplast was the first one out that's made out of a nylon material. Valplast is a great material. It's thin, it's light, it's almost invisible when it's in the mouth. It's difficult to adjust though, and it cannot be repaired because nothing sticks to it. So sometimes your laboratory can add to it mechanically, but usually they're going to tell you it's guaranteed out the door. And so if your patients have a Valplast partial, they need to know that it can't be repaired. So it can't add teeth to it or whatever. They tend to be unbreakable. So it's usually not being repaired because it's broken, unless a tooth breaks. But generally, if they want to add to it, it's not the best solution. Duraflex is a newer polypropylene-based material. It's a little less translucent. The coloring is slightly different, but the main advantage to it is that you can repair it. So that's helpful. As you're working with your laboratory, you'll find that some laboratories tend to like the Valplast better. Some labs tend to like the Duraflex better. If you have a lab that does both, I would be inclined to go towards a Duraflex just because of the repairability. But talk to your laboratory. You know, just like you have materials that work best for you clinically, your laboratory is going to have materials that work best for them, and you want them using the materials that work best. There are some nascent printing materials for flexible partials. So I think we're going to see within the next year or two this being flipping to a digital process, but right now most of these are still being done analog. Oh, and these tend to be mucostatic. So again, all the drawbacks of mucostatic, the material is not strong enough to make a rest out of. So it's not too difficult to see, hey, you got better aesthetics and more comfort with a flexible, and you have better bone retention and stability with a metal frame. So the combination partials make a lot of sense. You can design a metal frame for the lingual or palatal side that has rests to give the case more stability. And then the resonance, instead of being processed out of a hard acrylic, can be processed out of a flexible material. So that way you get the aesthetic advantages and the comfort of flexible clasps. Also, a big case like this one that's processed out of flexible material, not just the clasp flex, but the palate flexes, the saddles flex. So these cases, when your patient bites on them, they can feel a little bit mobile and less secure. Whereas when they bite on this, the hard metal grid work isn't going to flex. So you can have a lot of the benefits of both. You need to have enough vertical space to make one of these, which can be a challenge, and they can be a little bit more expensive. The only other downside to these is that you can't try in the clasps because the clasps don't exist till the very end. So you need to talk to your patient about there's going to be extensions on it, and you can't really test the retention until you get to the very end. But these can be a great solution for larger partials where you want the aesthetics of a clasp, but you want the stability of a metal frame. Like this case, this would be a great combination case because you could make this whole pallet out of, with say a horseshoe design, so you wouldn't have as much palatal coverage. This would be rigid, and then just process the saddles with the flexible to pick up those clasps. Clear frame. There are a bunch of polymer frame materials out on the market, and a lot of them are strong, but many of them are not that aesthetic. I'm thinking of the Altair material and some other ones that are out there. To me, the clear frame is really the only material that's ready for prime time. This is a material that is strong enough to make rests out of, so you can make a two-supported case rather than a tissue-supported case with all the benefits that you have from that. The material does need to be a little bit thicker than metal because it's not so not as strong as chrome cobalt is, but you can design these exactly like a metal frame partial. So anything you might design like an Acres clasp or indirect retainers or whatever, you can design in clear frame. This material can be purchased in a puck, so it can be milled or injected in your laboratory depending on what workflow. So there is a digital workflow for this and an analog workflow. You can talk to your laboratory about what they're doing. Sometimes your laboratory can make clasps out of the clear material. So if you have a situation where the clasp, you have a metal frame and you're like, I really don't want to see that clasp, your lab could make a clear clasp for you and then process it into the resin of the saddles. Keep in mind that, again, you won't be able to really, you can try it in wax, but the clasp, you can't really test the retention until it's processed because the clasp will move around in the wax. Again, there's pectin, PEEK, and PAEK, which are great strong materials, but they tend to look a little weird. So I think clear frame, if you want a material that you can make a two-supported frame out of that is not metallic, this is the one that's ready for prime time right now. So let's finish up by talking about the analog and then the digital workflows for partials. Depending on how many teeth you're replacing and how large the partial is, generally, the larger the partial, the more appointment steps you're going to want to make. But let's kind of talk about like a Kennedy Class 1 metal frame partial. How would you do that with an analog workflow? So you'll start out by taking your master impression and you're posing. If you can take a bite, so for a smaller partial, you could go ahead and take a bite at this time. A lot of times you'll need a bite block for a case that's missing a lot of posterior teeth. So when you're taking your impression, it's really, really important to use a crown and bridge type material. Don't use alginate for partials. The fit is very, very precise on these, and they're difficult. If any of you have had to fit them, you know these are very difficult to fit. If they don't fit, you usually got to take a new impression, remake it. Somebody's got to pay for it. It's just not a good thing. So use polyether or PVS just like you would for a crown and bridge case. And make sure you capture all the vestibular borders. You need to give your laboratory enough space to make a nice partial for you. So most of the time, like for a Class 1 case, you're not going to be able to get a good articulation with the models. So the laboratory will send you a bite block. Appointment number 2 is going to be taking the bite. Appointment number 3, usually you do your frame try-in with teeth on it. If you want, sometimes you can go to process. You got to kind of decide if there are aesthetic or functional reasons that you might need to alter the bite, alter the tooth position or whatever. And then your 4th appointment is going to be your delivery. As you guys know, if anything goes wrong, then you start adding appointments. But at the end of the day, even if you're doing 4 appointments with current reimbursement, a lot of times it's hard to make money doing these. And so again, like with dentures, many times we're like, oh, well, I don't want to do this because I can't really see a path to making money with it. Well, this is where digital comes in. And the coolest thing about digital, I'd say, are 2 things. One is that, as you guys know, if the software is capturing at basically perfect accuracy, 50 micron, 20 micron, whatever the software does, it'll capture the data. If it doesn't capture data, then you know it hasn't gotten to that level of accuracy yet. So you know that you're getting a good, accurate impression and that your framework, your partial is going to fit. The second cool thing is that when you take the records, even if you only have a handful of teeth, if the person can bite accurately, you can capture the bite with your iOS. One little tip that you want to do is when you're scanning the bite, always scan both sides of the arch. Even if the software snaps with the first side, what we found in the laboratory is that sometimes that other side isn't as accurate as it is when you come around to the other side and scan that too. So always, it's best practice to scan both sides of the arch so that way you get a nice bite. So if you're doing like a smaller partial, you can do scan and deliver. So all of a sudden now you're down to 2 bites. I mean, 2 impressions. Sorry, not 2 bites, two appointments. And this is going to be a much more financially realistic workflow for you. Every once in a while, you're going to have your anterior teeth, or you're going to have a bite where you're not real confident, and you may want to do an appointment where you either do a try-in for like a flexible, or you do a frame with try-in for a metal frame or clear frame, something like that. But a lot of times you can go to 2 appointments or at least 3 appointments. And again, because of the accuracy, you're less likely to have extra appointments basically trying to deal with problems. So I feel like, you know, today iOSs are kind of your silver bullet to get your workflow going faster for partials. Here's a little screenshot of different kinds of different codes for some of these workflows that can help you, your CDT codes. So I'll leave that up for a minute and you guys can take a picture of it. So that's all I have tonight. Thank you very much for attending. I hope you got something out of that.